Good evening. So I shall be talking about regional priorities based on the perspectives of the Asia Pacific Society for Immune Deficiencies. And I shall be stressing on how does one diagnose primary immune deficiencies in a resource limited setting, a setting that we encounter in our day-to-day life in the Asia Pacific region. So the Asia Pacific region is a very special region. It has 60% of the world's population. It has more patients with PIDs than the rest of the world combined. It is home to many developing countries and it has significant diversity. We have countries as well developed, as advanced as Japan, the Hong Kong semi-autonomous region, Singapore, Australia. On the other hand, we have many countries in the Southeast Asian region which are not that developed. And this diversity is very special to the Asia Pacific region. Perhaps this region is more diverse than any other region in the world. So what are our priorities? First and foremost, we have to increase awareness about primary immune deficiencies in this region. And this is something which is of great importance to all of us. How does one do that? There are a lot of problems because infectious diseases are very common in developing countries. Physicians as well as pediatricians have a very low threshold for diagnosing infection. So much so that many physicians may not think beyond treatment of infection. And that is where problems arise. We have lack of awareness about PIDs amongst both physicians and pediatricians, and a reluctance to accept a diagnosis of PID amongst the laity. As a result, diagnosis of PIDs is often delayed and even missed altogether. So this is a very special challenge we have in the APSID region. What are the numbers we are dealing with? These numbers are staggering. If you take the approximate prevalence of PID as 1 in 2,000 of the population, more than 1 million people in India, more than 1 million people in China would have a PID. Majority are unaware that they even have a PID. As a result, an overwhelming majority remain undiagnosed. What have we done? Well, we have done a lot. We have developed several networks. We have formed several societies to improve upon this awareness. We have the Asian PID Referral Network, which is based in Hong Kong, and that has done commendable job in increasing the awareness about PIDs in this region. And it has also helped us in getting molecular diagnosis for these patients. We formed the Indian Society for Primary Immune Deficiency in 2010, and we have been holding meetings throughout the length and breadth of the country, and that has also helped us in increasing the awareness about PIDs. We have the Japanese Society for Immunodeficiency and Autoinflammatory Diseases, which has collated very important data on the prevalence of PIDs and on the detailed diagnostic modalities that they use for diagnosis of PIDs as well as autoinflammatory diseases. Then we have a network of PIDs societies in the Southeast Asian region, comprising Malaysia, Thailand, Vietnam, Indonesia, Singapore, and the Philippines. So a lot of work has been done in this region, but we did not have a regional society for PID in this region. For instance, in the US, we had the Clinical Immunology Society. We had the Latin American Society for the Latin American region. We had the African Society for Immune Deficiency. And of course, we had the European Society for Immunodeficiencies. This region, till very recently, did not have a society of its own. In 2014, a group of pediatricians met at the Asian Society for Pediatric Research meeting at Osaka. And led by Dr. Yu Langlao, we formed the Asia Pacific Society for Immunodeficiencies. It was at this meeting of the ASPR that the foundations for the APSID were laid down. And in 2016, we held the first scientific congress of the APSID in Hong Kong. And this was a game changer as far as PIDs were concerned. The second priority is that we have to improve the clinical acumen of pediatricians and physicians for diagnosis of PIDs. This is of great importance because investigations are not only very expensive, they are also not easily available. So we have to depend a lot on our clinical acumen. We must remember that diagnosis of PIDs is not difficult. And it is possible to make a syndromic diagnosis of PIDs at the bedside if we are aware of these disorders, if we are aware of the clinical presentation of these conditions. The first step is that we have to suspect PID, and that is often the most important step. I was taught by my teacher, Professor Roland Levinsky, at the Hospital for Sick Children, Great Ormond Street, London, way back in 1990, that diagnosing PIDs is not difficult. How do we suspect PIDs? We should suspect a PID whenever a child has very frequent infections, very severe infections, an unusual clinical presentation, or infection with an unusual microorganism. If we keep these four things in mind, it's not difficult to suspect and to diagnose PIDs. I shall show how. This is a 3-year-old boy who has had recurrent otitis and pneumonia. It's a spot diagnosis because what you see here is absence of tonsils. So in such a clinical setting, if you do not see tonsils, there is virtually no differential diagnosis other than X-linked A-gamma globulinemia. This is a small baby who has a bad lung. The baby had lymphopenia, and there is virtually no differential diagnosis because if you can see the arrows, these changes in the ribs are very typical of ADA deficiency, adenosine deaminase deficiency. This cupping at the ends of the ribs is so very typical of ADA deficiency that you can diagnose this condition virtually at the bedside. This is again a very typical presentation in which a patient has a liver abscess, he has perianal draining sinuses, he has lymphadenopathy, a sinus here. This is virtually book picture chronic granulomatous disease. If one is aware of this disorder, there'll be no difficulty in picking up the diagnosis. This is a 12-year-old boy who's remained unwell for the major part of his life. And these are the kind of lesions that he has. This is a spot diagnosis of leukocyte adhesion deficiency. There's hardly any investigation that one requires in these patients. This is a 10-year-old boy who's had several episodes of pneumonia and recurrent staphylococcal abscesses. But what was the clue? That these abscesses were cold abscesses. That means there were no signs of inflammation. And if you notice, the child has coarse facial facies and he had a very high IgE. The X-ray of the maxilla showed that the child had not lost his primary dentition. So this is book picture autosomal dominant hyper IgE syndrome. Sometimes PIDs can linger on for years together, as shown in this patient who was 35 years old and he had been unwell for several years. He had had recurrent bouts of pneumonia and diarrhea, and what he had was common variable immune deficiency. But he suffered for many years before the diagnosis was made. The third priority is that we have to recognize and address diversity in the region. This is inbuilt in this region. For instance, we have high rates of consanguinity and endogamous marriages in many parts of the Asia-Pacific region. What is the result? The result is that disorders that are X-linked recessive in the Western countries may turn out to be autosomal recessive here. For instance, in Chandigarh, the commonest type of chronic granulomatous disease that we see is autosomal recessive, not X-linked recessive. Similarly, the phenotypes of PID may be very different. We see many children who have high incidence of arthritis in XLA, probably because of delays in diagnosis. Even within a country, there may be variations. We know that the pattern of primary immune deficiencies in North India is very different from that seen in Western India, and these are published data. The pathogens that infect these patients may also be different. In most of the Asia Pacific region, BCG vaccine is given routinely, and it can impact several PIDs. For instance, it can impact patients with chronic granulomatous disease. It can impact patients with severe combined immunodeficiency, and disseminated BCG infection may be the presentation in these patients. Similarly, because of the high incidence of Mycobacterium tuberculosis, we have seen patients with chronic granulomatous disease who have tubercular infection. This is rather uncommon in patients from the West. Then in some regions, we have infections with unusual organisms, for instance, Burkholderia pseudomoli and Penicillium anephai. These are organisms which are not seen in the Western world. The fourth priority is that we have to improve our diagnostic facilities for PIDs. And this is a very challenging task because not many centers have laboratory protocols and the technical wherewithal in place to diagnose these conditions. There is a lack of appropriate facilities for molecular and genetic diagnosis. And then again, there is diversity. On one hand, you have countries like Japan, Hong Kong, Taiwan, Korea, Singapore who have well-established laboratory services. We have countries like China and India where there are good laboratory services, but mainly in major cities or research centers. You have countries like Philippines, Vietnam, Thailand, and Malaysia where the laboratory services are coming up rapidly. And then you have countries like Nepal, Bhutan, Cambodia, where the laboratory services still need a lot of augmentation. So in China, for instance, you have two very big centers at Chongqing and at Shanghai. We have a center in Beijing, but then the western part of the country is not that well represented. In India, we have the Foundation for Primary Immune Deficiency Diseases, which has helped set up several centers in the country. But even these 8 centers are not enough for a country as big as India. What have we done? Well, led by Dr. Yu Lung Lau from the University of Hong Kong, we have several academic collaborations within the Asia Pacific regions. And as a result of these academic collaborations, we have been able to get molecular diagnosis, genetic diagnosis in a large number of our patients. And this has been going on for more than 10 years now. So as a result of this referral network, several centers in the Asia Pacific region have had molecular diagnosis at their doorstep. This was not possible around a decade ago. So this is a major step which has helped us in diagnosing our patients. An example of how we have evolved at Chandigarh will further explain this issue. Till 2008, we were doing immunoglobulins by radial immunodiffusion. This was the time when we got our first nephelometer. We started doing immunoglobulin assays by nephelometry. Next year, we started flow cytometry in our own laboratory. A few years after that, we set up facilities for BTK protein estimation. But the game changer was in 2015, when the Indian Council of Medical Research set up the Center for Advanced Research in Primary Immune Deficiencies, and this really helped us in developing our facilities. And we are at a stage now where we can do molecular analysis, antenatal screening, genetic diagnosis for many primary immune deficiency disorders right in our own laboratory at the Advanced Pediatric Center. What has been the result of these collaborations? Well, we have had a series of publications emanating from the Asia Pacific region. All the authors in this publication are from the Asia Pacific region. Publications like these were not there 10 years ago. So this is another such publication again led by Dr. Yu Lang Lau, but with collaborations from many centers in this region. This is our own publication, but it also reflects the help that we have received from Dr. Lau's lab in Hong Kong, as well as from our collaborators in Japan. This again is our own publication. And this publication is on how we have evolved as far as flow cytometry is concerned, and how we have got over the difficulties that we encountered in setting up facilities for flow cytometry at our center. We have also collaborated with several centers the world over, and all this has been possible because of the facilities for molecular diagnosis that we have available in this region now. And this is well reflected in the number of publications that have come up from India itself. So since 2010, there has been a sharp increase in the number of scientific papers coming up from centers within India. The fifth priority is we have to improve the teaching and training facilities for doctors. So in India, we have postdoctoral training courses in clinical immunology at many centers, but most of these centers, they specialize in rheumatology. And it's only over the last 7 to 8 years that these centers have also started setting up facilities for primary immune deficiency. At Chandigarh, however, we have 2 postdoctoral courses, one for pediatrics, the other one for adult physicians. And as a result of these training opportunities, we are now training a new generation of physicians in the nuances of primary immune deficiency disorders. As a result of the formation of the APSID, we have held several schools, summer schools, winter schools, as well as symposia throughout this region. And that has definitely helped in improving the awareness about PIDs in this region. The next priority is how do we improve the management of PIDs? Again, we have to take diversity into consideration, because there are countries like Japan, Hong Kong, and Taiwan, where intravenous immunoglobulin and other resources are easily available. And these countries, in these countries, the quality of treatment being available is as good as that in the West. We have countries like China and India where free immunoglobulin is available, but not in all regions and not in all states. In countries in the Southeast Asian region, IVIG is becoming increasingly available, but is not available to all patients. And in some of the other countries, this is just not available at present. Throughout this region, we still do not have easy access to subcutaneous immunoglobulins, although in India, we have one company which will be marketing this product later this year. We do not have gamma interferon easily available in major parts of the South Asia Pacific region. Hematopoietic stem cell transplantation facilities are also easily available. And gene therapy is not yet an option for our patients in this region. Even for stem cell transplantation, we have countries in this region with high GDPs like Japan, and there stem cell transplantation is being done for diverse indications for disorders such as severe combined immunodeficiency, Wiskott-Aldrich syndrome, CGD, leukocyte adhesion deficiency, even for monogenic forms of combined immunodeficiency. Countries with low GDP such as China and India, we still restrict stem cell transplantation to mainly for severe combined immunodeficiency and Wiskott-Aldrich syndrome. And this slide reflects this bias in another way. In the Asia Pacific region, even after diagnosis of PIDs, we try to manage these patients with prophylactic antimicrobials, intravenous immunoglobulin, and only a minority get stem cell transplantation. On the other hand, in Western countries, The majority of these patients are offered stem cell transplantation or gene therapy. IVIG is freely available, and the prophylactic antimicrobials are only required in a minority where nothing else can be done. Newborn screening for severe combined immunodeficiency is available in all states in the US and many European countries, and that helps in early screening for combined immunodeficiency. But in the Asia Pacific region, this is not yet a practice because the cost of the TREC assay is a major constraint. So to summarize, approximately 60% of PID patients in the world reside in the Asia Pacific region. There are major challenges in diagnosis and management. Outcome of patients with PIDs in this region is steadily improving, but we are well aware that we still have a long and arduous journey ahead, but we are ready for the challenge. So this is what we have from the Asia Pacific region. We are progressing fast, but we still have a long way to go. Thank you very much.